all the guidelines that you use to take care of your patients, as well as the NIH and CDC HIV prevention and opportunistic infections guidelines. She's research director at Emory University. She has led the way in STI research and is the author of several landmark studies regarding the clinical epidemiology and treatment of genital chlamydia and the clinical evaluation of the first herpes simplex 2 vaccine, which is a work in progress. She is here to speak to us today about STDs, Essentials for the Clinician, Dr. Borkowski.
It's always nice to start this conference with some graphic pictures after breakfast. So hopefully everybody will be awake and it will continue to keep you awake. So I only have a very short period of time to talk about a large number of pathogens, a very challenging task. So what I thought I would do was I'm going to go quickly. I'm a quick speaker. If I don't get all the material, it's there in your packet. These are my learning objectives. Most of my current research has to do with HIV and hepatitis C clinical trials, which I do a lot of that. And all my STD-related research is done at CDC, so I have nothing to disclose. There are over 40 pathogens that are sexually transmissible. I'm not going to try to get all of them. I just wanted to categorize them for you here. Just to think the way I think about them and putting them in the context as an infectious disease doctor. Bacterial, viral infections, and parasites. One of the main things I want to get you to remember as we talk about things is hepatitis, which is another one of my passions, is also a sexually transmissible disease. Hepatitis A, B, and C. When we look at what the estimated burden is in the United States of sexually transmitted infections, these are very old data, but the most recent that we have, over 19 million sexually transmitted diseases are estimated. And I just want to give you a flavor of what is the ones that are the highest prevalence. Trichomonas, HPV, and even though chlamydia and gonorrhea are the number 1 and 2 reportable diseases to CDC, some of these other viral diseases trump them in terms of prevalence. What we're looking at in terms of worldwide is 350 million, the most recent estimates from WHO, with the most common being trichomonas. Now, in particular, this is a women's conference, and why are sexually transmitted infections important in women? Because most of them are asymptomatic and can lead to significant reproductive health complications. The symptoms are often confused either by women themselves or by providers for another condition because they can be very subtle in terms of their presentation. I mentioned before the reproductive health consequences, in particular for chlamydia, causing infertility, stillbirth for syphilis, premature birth, congenital infection. Neonatal herpes is a devastating infection. Syphilis, congenital syphilis, we're starting to see a small rise in congenital syphilis, especially in our states that are right next to Mexico, and then HIV infection. And we'll talk a little bit at the end about HPV, and not only its link with cervical cancer, but also its increasing link with oropharyngeal cancer. So first let's talk about screening and what the recommendations are for screening. Particular for women, these are the U.S. Public Service Task Force recommendations for screening. And when we think about this, especially with implementation of the Affordable Care Act, things that are rated as A and B are going to be taken care of by the Affordable Care Act. But in particular, what do we need to think about? Chlamydia screening, especially because chlamydia is mostly asymptomatic, and screen all sexually active women under the age of 25. What about gonorrhea? The issue with gonorrhea is really that the data actually point to a risk-based strategy, not a universal strategy, but more of a risk-based strategy based on risk factors. And I list there for you the website for U.S. Preventive Services Task Force to get all the details, or you could go to the treatment guidelines and get those details. Cervical cancer, hepatitis B, and also the importance of high-intensity screening for behavioral counseling. So asking women what their sexual practices are, how many partners they have, what orifice is being penetrated, some things that we really don't ask a lot. And in terms of looking at surveys, in terms of sexual activity, especially in women, up to 20% of women will engage in receptive rectal intercourse. And unless you ask that question and screen for sexually transmitted infections at that orifice, you may be missing infections. And then we'll talk a little bit about HPV vaccination at the end. So here is what I've been involved with for the past 15 years with my contract work at CDC. This is really a management and treatment document, not so much a screening document, but we do have in there the screening recommendations from U.S. Preventative Services Task Force. And again, I mentioned some of this before, to test all sexually active women regardless of their sexual activity, and that includes lesbian women as well as women that have sex with men. Ask the questions about which orifice was penetrated. The other big issue is the recommendations for anybody diagnosed with chlamydia or gonorrhea to repeat that test within 3 to 6 months because of the high incidence of reinfection, about 15%. And then we'll talk a little bit about trichomonas, which is actually a very prevalent sexually transmitted disease that hasn't gotten much attention. It's like the Rodney Dangerfield of STDs. People don't give it much mind. They think it's a nuisance infection. But it's really of concern because of the huge racial disparities and also because of its association with HIV acquisition and transmission. So what can we do in terms of giving our women prevention guidance? I've talked about what we call the 5 Ps: partners, pregnancy protection practices, and past STDs. We can pre-exposure vaccinate them. We'll talk a little bit at the end about HPV. Also, again, I mentioned that hepatitis A and B are sexually transmissible, and we refer you to the treatment guidelines to look at the specific recommendations for who to vaccinate for A and B. And then what kind of recommendations can we give about condom use? There's a number of good information out available on condoms. You can go to the CDC. There's a fact sheet on condoms. But to distill it down to something that you might find relevant, the best information and evidence we have is that condoms are the most protective and the most effective in those sexually transmitted infections that are transmitted in mucosal fluids. So HIV, chlamydia, gonorrhea, and trich. We have less information on herpes and HPV, but they still have limited effectiveness because, as you know, there can be areas that are not covered by the condom, and you can still get transmissibility. And then again, several years ago, we heard about the dramatic 3 trials that were done in Africa showing the association with male circumcision to reduce the risk of HIV acquisition. Some of you may not be aware that some of those studies also showed a decrease in incidence of HPV and genital herpes. So what we're going to go through next is some clinical presentations that you might see, and we'll talk a little bit about what are the diagnostic and evaluation strategies. So the laundry list is something that we've all seen from medical school in terms of how we differentiate genital ulcers. What I basically put here for your reference, what you see in yellow is what's most important. However, most of us are wrong in terms of our diagnostic acumen because STI presentation can be very subtle. There can be multiple infections at once. If patients are immunocompromised on steroids, the presentations may be very different. So I just put tables here for your reference so that you can be aware, you can look back later in terms of the presentation. Some of this we'll talk a little bit about as we talk about some of these pathogens. This is the typical appearance that you may see if a woman comes in, or you may read about with genital herpes. You see the small circular lesions. They're extremely painful. Women can have bilateral inguinal adenopathy. And even in early infection, primary disease, patients can be sick for 2 to 3 weeks. We know that about 1/3 of patients are viremic. They can have exudative pharyngitis. They can look very sick and feel very sick. The problem, as I mentioned, when you're trying to evaluate a general ulcer, our diagnostic tools, unfortunately, in some of these infections are not so great. We also mentioned that our clinical expertise sometimes is not that great because these infections can be very subtle. There can be multiple agents, as I mentioned. Patients can be immunocompromised. Also, there's different prevalences in different parts of the world. There is still sex tourism going on out there. People are going to other countries and having sex with commercial sex workers and coming back to the United States with interesting presentations. So unless you ask appropriate questions that may help you in terms of your diagnosis, you're going to miss some things. So how do we evaluate patients? We really don't have any more point-of-care tests for syphilis, as thinking about that last patient. We don't have DFA anymore that was available, direct fluorescent antibody. Most of us don't have dark fields in our practice, so we rely on serology for herpes. For HSV, we've got herpes culture or PCR, which are the best diagnostic tests. However, we don't have a point-of-care test available for herpes. The zinc smear should not be used. It's very insensitive, and it can pick up multiple other pathogens besides HSV, other herpes viruses. And if you don't know, which we don't know about 25% of the time, you biopsy. And the other important point on this slide is that you treat for the diagnosis most likely. You don't wait for that test result to come back. This is what is fueling some of our syphilis epidemic, where people are waiting to see what their test results are. If you're concerned and if you're thinking in a certain way, you go ahead and treat and then wait for those diagnostic tests to come back. So since herpes is the main infectious cause of genital ulcer disease in the United States, I wanted to take you through some of the prevalence data that we have. This is based on using type-specific serologic testing, which is the best serologic test that we have available to determine past exposure to herpes. And now what we can say is about 1 to 4 to 1 in 5 in the U.S. population is infected with herpes. And you can look at the other distribution in terms of where we may see increasing prevalences. This was a really important study that was done by one of my colleagues, Fujitsu, and what it basically showed was differentiating by number of partners. So the increased risk you have of acquiring herpes is based on number of partners and also on race. Also, herpes, if you look at seroprevalence, is much more common in women than men at every age group. Also, about 30% of genital herpes now is due to type 1 herpes. Some of that is due to the association of oral genital contact and saying that oral genital contact is safe, especially amongst our adolescents who are worried about getting pregnant. So there's a lot more anal sex, there's a lot more oral sex because of the concerns for getting pregnant. And I also mentioned about primary infection. Most of these infections are relatively asymptomatic. So most people are very surprised when, if you test them using a type-specific test, they have genital herpes. This was also, in terms of your counseling, is a really important paper. Since most of the herpes is transmitted by subclinical shedding, and you don't really know when you're shedding, this paper actually looked at men and women and had them culture their genitals for 30 days. And what it basically showed was that people that were symptomatic as well as asymptomatic shed the same amount of DNA, which is concerning in terms of thinking about your counseling messages, because one of the questions I always get is, when can I have sex without a condom? You can't predict. You can't predict when you're going to shed. And there's been elegant shedding studies that have been done from the University of Washington showing that some people have these short bursts of shedding. Some people have them 4 to 5 times a day. And you really can't predict when somebody's shedding. This is an example of a woman that presented with vaginal discharge. And unless you actually did an exam and saw these lesions on her cervix, she didn't have any external lesions. All she had was cervical lesions and an endocervical discharge. And this was primary herpes infection. She actually came in complaining of vaginal discharge. This is another common presentation, and I know it's kind of hard to see, but if you can imagine The vagina is at the top of the slide. What you're looking at is about 6 o'clock, and you see these recurrent tears. So recurrent tears, they also almost look like, or feel to patients like paper cuts. And sometimes it's associated with lack of lubrication, or they associate it with vaginal trauma. This is a very common presentation of genital herpes. So if you culture the organism, if you culture for this, and this is herpes, this is a great place for you to look for herpes infections when you're doing your exam. So we mentioned this before, cell culture or PCR is the way to go. Don't ever order an IgM test. It is totally unreliable. The currently available IgM tests are not reliable, and I get into these discussions all the time with patients and athletes who I get asked to be part of expert testimony in terms of who gave them herpes. And everybody looks at the IgM test, and you know, we can say this over and over, IgM tests mean nothing. Herpes is incredibly hard to prove, he said, she said, very difficult. So if you are thinking about primary herpes, your serology won't help you because it takes months to develop an immune response. If you're going to be using herpes serology, you have to make sure it's type-specific serology, and these are the indications. We don't recommend general population-based screening for herpes for one reason. Even though these tests are good, there's problems with specificity. So if you're dealing with a low prevalence population, you have a chance of having a false positive test. The definitive test is a Western blot, which right now is only done at the University of Washington, but that's our most definitive test for herpes. Which drug to choose? All these drugs work well. The data I can tell you is that valacyclovir and acyclovir are very good for suppression. Famciclovir is slightly less effective. And the acyclovir resistance that we're seeing is really in immunocompromised individuals. We're really not seeing it in immunocompetent men or women. And this was a very important study when you're counseling patients and talking to them about how to decrease risk of transmission to a partner. By an index patient taking valacyclovir 500 milligrams once a day can decrease transmission risk to a partner, a heterosexual partner, by 50%. So that in combination with condoms and counseling can help to decrease transmission risk. However, knowing that this virus is very inefficiently transmitted, looking at long-term heterosexual couples in long-term relationships, transmission is only about 5 to 10% per year. So it's relatively inefficient. And then this is a patient I saw with herpes, and this is an immunocompromised patient. So in immunocompromised patients, herpes can present in strange places. And the keys here were the scalp appearance of the lesion and the beefy appearance of the lesion. It looks like granulation tissue, and this is what cued us into herpes. And the diagnosis here was made by a combination of culture and biopsy. Next most common cause of genital ulcer is syphilis. Syphilis, not much of an issue in women now, but there's a slight uptick. Most we're seeing now in women, in syphilis is due to men who have sex with men. There's been a dramatic increase. Some of the increases you saw in the 90s, there was a dramatic increase, especially in women associated with exchange of drugs for sex. The problem with syphilis is we're not picking up primary lesions. We're picking up whatever group you look at, heterosexual men, gay men, or women. We're picking up secondary disease. We're missing primary disease. This is an example of a woman with primary syphilis. Kind of an innocuous-looking ulcer. She may not even feel it because syphilis is relatively painless. And so if she continues to have sex and not know that it's there, again, she can transmit it to somebody else. The bigger concern is other places that we may or may not look. This is a tongue lesion, and the only way this was diagnosed was by a biopsy. Because there's there's non-pathogenic treponines that live in our GI tract and in our mouth, so you can't use a dark field scope. This is an anal lesion. And you can see it kind of about down here about 5 o'clock. And unless you're looking or you're asking patients questions, are you engaging in anal sex? Most people don't look at bottoms, except for the gynecologists who do pelvic exams, or your internists that do exams. But again, this may be innocuous, and unless you're specifically thinking about it or looking at it, may be missed. I mentioned this before about how to diagnose syphilis. There's no good definitive test. Most of us don't have dark fields. PCRs aren't point of care. So we rely on serologic tests, which is a non-treponemal test followed by a treponemal test. Everybody gets confused over syphilis. Nobody understands it. These tests are crappy. They've been available for 50 years. They're horrible. They're not that good. However, what's even made it more complicated is some states, blood banks now, are screening with treponemal-based tests first, which makes it very confusing, because if you've been exposed in the past to syphilis, they'll always be positive. And so you may develop instances where you have a positive treponemal test and a negative RPR. This is way too complicated a subject to discuss in 2 minutes. I would refer you to, and I could talk for hours about it, but it's very complicated. I would refer you to an MMWR that was done last year that talks about, it's called reverse sequence serologic screening. Or if anybody has any specific questions, I'll be happy to answer them. The other issue is, think about syphilis like Lyme disease. It's a systematic disease. It disseminates even with primary infection. You're going to find the bug in your CSF even with primary disease. Most of us have competent immune systems that we can eradicate it, and there's no problem. But again, it can occur at any stage of syphilis. And if you're HIV infected, the management principles are similar. Typical rash that you might see in secondary syphilis. However, also what we may see is alopecia, mucus patches here in the mouth, and condyle ovulata, which it can be on the perineal area. How do we treat it? From primary, secondary, early, latent, we're going to treat with a single shot of benzathine, regardless of whether you're HIV infected. Don't give additional shots. If your patient's HIV infected, there's no data that shows it's any better, that 3 is any better than 1, and your patients will thank you for it because it's quite a painful shot. What about if your patient is pen allergic? We have data on doxycycline and ceftriaxone. Azithromycin works well, but the problem with it is it shouldn't be used because of the development of resistance and treatment failures that have been reported. This is especially important because this drug, especially in a pregnant woman, does not reliably cross the placenta, and we don't have good data in terms of fetal outcomes. Next, I'm going to move from genital ulcer disease to cervicitis. Frequently asymptomatic, or women may come in complaining of a vaginal discharge. And again, unless you look, you're not going to see that this discharge is actually coming from the cervix. Either pus coming out of the cervix, or when you put that swab into the cervix, easily induced endocervical bleeding. The etiology most likely is chlamydia, gonorrhea, trichomonas, herpes, or BV. BV may surprise you, but BV can be a cause of cervicitis. The diagnosis are using a nucleic acid amplification test for chlamydia or gonorrhea, looking for trick and BV. And then we treat with either azithromycin or doxy. The component in men, we need to know a little bit about men, since if they have urethritis, we need to think about the women. When men come in with a drip or dysuria, the main causes are most likely chlamydia and gonorrhea. However, I highlight this one bug that you may not be aware of, and you may not be aware of it because there's no commercially available tests to detect it. There's PCRs that are available, but they're available in research settings. And why is this bug important? Because it's a common cause of NGU in men. Women, the data is emerging, but it's a little bit more conflicting. And the difficulty with this bug is it doesn't respond well to doxy. You have about a 75% failure rate. So if you give your patients doxy, you may fail. The other concern here is trichomonas, which can cause about 5 to 20% of urethritis infections in men. And herpes, another big cause. If a man presents with urethral meatitis, that's extremely severe, you should think about herpes. And depending on where that penis is inserted, you can have enteric organisms. And that's not only in men who have sex with men, that's also in men who have sex with women who engage in receptive anal intercourse. So the most common cause of cervicitis and urethritis in men continues to be chlamydia. Where do we see chlamydia? Mostly in our young folks, and that's why the U.S. Preventive Task Force recommends screening for all sexually active women under the age of 25. So our primary focus of screening really should be women. Then you ask, well, what about the men? The men, at this point, in terms of cost-effectiveness data, the best data we have shows that you should probably do selective male screening, where the prevalence of chlamydia is high. Adolescent clinics, corrections, young men, previous STDs, or those in the military. Treat the same way, azithromycin or doxy, and again, retest 3 to 6 months after primary infection. Long-term consequences you're aware of: tubal factor infertility, ectopic pregnancy, chronic pelvic pain. Chlamydia is the leading infectious preventable cause of tubal factor infertility, and it can be prevented by us doing a better job in terms of screening. Just wanted to mention about expedited partner therapy, and what that is providing medications to a partner that is unable to, for that partner unable to get into healthcare services. You need to check with your state to see what the legal ramifications are in your state. And a lot of states have been giving partner packs so that you can treat the men. When your woman gets diagnosed with chlamydia, give them partner packs so that you can ensure they're getting treated. Gonorrhea, I'm going to quickly go through the rest of these since my time is running short. What do I need to tell you about gonorrhea? Gonorrhea rates are flat, but starting to creep up a little bit. And where we're seeing it is in young women. Again, screening is an important component of control. I mentioned before, these are the U.S. Preventive Service Task Force guidelines. And our NAT testing are the best tests available to detect chlamydia and gonorrhea. Our guidelines, I'll be coming out for laboratory guidelines for chlamydia and gonorrhea, and actually the preferred specimen type for chlamydia and gonorrhea will be self-collected vaginal swabs. You just send, instead of a urine, you just send the woman in with a swab, have her swab her own vagina. Very good reproducibility rates and equivalent to provider-collected swabs. And much less, so you don't necessarily have to do a pelvic if they're coming in for a screening test. You can just have them do a self-collected swab. The biggest problem we're seeing with gonorrhea now is antimicrobial resistance. You may have seen the article in the New England Journal a couple of weeks ago about impending doom for no drugs. And there's a lot of truth to that in terms of what's happening. This bug is incredibly versatile and has gone through multiple antibiotics. You may have remembered this story with the emergence of fluoroquinolone-resistant Neisseria gonorrhea, and it's following the same pattern as penicillinase-producing Neisseria gonorrhea did in the late 70s. Comes from Southeast Asia, comes in the West Coast, first gets into gay men, and then gets into the heterosexual population. The same thing is happening with quinolone, with cephalosporin-resistant gonorrhea. So, because of that, we've changed our treatment recommendations. Gonorrhea now should be treated with 2 drugs. This is still confusing for folks. We increased the dose of ceftriaxone, and we're giving them dual therapy for gonorrhea, regardless of your chlamydia test results. So if your chlamydia is negative, your gonorrhea is positive, you still treat with 2 drugs. Ceftriaxone at an increased dose in either azithromycin or doxy. For trichomonas, the interesting thing about trichomonas is we now have a nucleic acid amplification test, which is our best, most sensitive test to detect trichomonas. We've also had some data that shows a high prevalence, again, of reinfection. So we'd recommend rescreening women 3 to 6 months after trichomonas treatment. We treat with either metronidazole or tinidazole. And there is some data if your patient is HIV infected that we need to treat a little differently. Not the 2-gram dose, but a more extended duration of therapy because of some increased treatment failures associated with TRIC. And this is again showing you data that these nucleic acid amplification tests are much more sensitive. And your wet prep that you do in your clinics is so insensitive. And unless you do it within 5 minutes, it's somebody gave the analogy, it's like trying to catch a swimming salmon. You just can't do it. It's really hard to do. For BV, the thing you need to know, what's new about BV? We don't have a cure-all. BV is still a conundrum. We've got a new alternative regimen and some recommendation for recurrences. We know about 1/3 of women recur, and we're still puzzled by the vaginal microflora in terms of trying to eradicate this infection, especially in recurrent in instances of recurrences. I put down here, I'm not going to go over all these bullets, but there may be associated with increasing evidence of biofilms that increase the risk of treatment failures, specific organisms that are resistant to some of our antibiotics, and certain risk factors. And don't use yogurt. I've had people using yogurt douches and putting yogurt up their vaginas. Those dairy lactobacillus strains don't adhere to the vaginal microflora, so it's not that helpful. Let's end with HPV, because there's some interesting, intriguing data. You know about the association with cervical cancer and penile cancer. I really want to just touch a little bit about what's happening with oral cancer. You may have seen this JAMA article that came out that raised a lot of attention about oral sex. And this shows the association of the number of lifetime partners with prevalent HPV in the U.S. population. So again, the more partners you have associated with increased risk of HPV acquisition. And then this very interesting article that came out, which is basically modeling the projected number of patients with oropharyngeal cancers and cervical cancers. And if you look at the line here in yellow, this is the I can't even see this, but the projected increase here in oropharyngeal cancers is expected to exceed cervical cancers in the next 15 to 20 years. So what does that mean for counseling? We've written a paper that you can find in Clinical Infectious Diseases 2011 that actually has a counseling piece for providers and for patients. If your patient has HPV, you can give them this little information sheet, because a lot of the messages are very difficult in terms of what can I do with oral sex? What do the dentists do? There's some dentists out there that are now using the HPV nucleic acid test to swab people's oral mucosa. That is fraught with a lot of problems. Also, who should we test in terms of HPV, these tests? These are the only 2 indications right now. Ask pap smear in a woman in conjunction with a pap smear over the age of 30. When a woman comes in or a man comes in saying, I want to be screened for everything, that doesn't mean that you swab their genitalia for HPV. That makes no sense. Also, in terms of the genital warts treatment, we've got cinecatechins that are available. A lot of the side effects from these are a lot like imiquimod. And if you use imiquimod, there's increasing data about the use of forming vitiligo associated with the use of Eldera, so you need to be concerned about that as well. And then HPV vaccine, I'm just going to end here. You know about that it was licensed in females and males, and most recently recommended for routine use in boys. However, the HPV uptake in the U.S. has been relatively low. But I just wanted to show you to end some dramatic results from Australia, which are just phenomenal. And what they're doing in Australia is that they're actually giving school-based vaccination. And you can see this dramatic decrease in the proportion of women with genital warts. I was just at a meeting this week, the STI conference, here in the United States, showing also the same trends in family planning clinics here in the United States, as well as looking at MedStat data, showing a slight decrease in genital warts. We don't have as dramatic decrease here in the U.S. because we don't have the uptake, but this is pretty dramatic. So just to end, these are the 5 things we need to think about: education and counseling, asymptomatic infection, effective diagnosis and treatment, which I've tried very quickly to go over with you. Remember the partners, pre-exposure vaccination, I've listed for you some specific resources for women. One of the things that I forgot to mention on here, there's a really cool website called I Got the Kit, or IWantTheKit.com, where women or men can go and do anonymous STD testing over the internet, and to a very reputable lab here in the United States. And then we've also got a website at CDC, Get Yourself Tested, which is, again, talking about the importance and empowering people to get themselves tested. So thank you very much for your attention, and I'll be happy to answer any questions. Okay. There's mics in the aisles. If anybody has any specific questions. Yes.
Could you comment on the new Gardasil shot that will be out in 2014?
So you mean the nanovalent?
Yeah, it's with 5.
Well, it's actually a nanovalent.
Okay, thank you.
So there's a